right, well, I'm going to get started and then people can join as I'm giving a little intro. Welcome, everyone. This is the fourth seminar in our series, Behavioral Health and Tobacco Dependence Treatment. And we are so glad to have you guys with us today. My name is Emily Koyagi, and I'm the Program Manager for UK's Behavioral Health Wellness for Environments, Behavioral Health Wellness Environments for Living and Learning, otherwise known as Be Well. And today we have the pleasure of hearing from Dr. Lovoria Williams. She's going to be presenting Pharmacotherapy Considerations for Tobacco Cessation, Special Considerations with Neuroleptics. So we are really looking forward to hearing from her. Before we get started, I'm just going to mention a few things. We are recording this seminar. I know there are some conflicts some people had today. So if you have some colleagues that wanted to attend, I'll send out an email probably tomorrow that has the link to the recording. So please feel free to share that with those you know who may have missed it or who might be interested in what we talk about today. During our time together, please feel free. We want it to be interactive and comfortable conversation. So if you want to ask a question in the chat or raise your hand virtually, I'll keep an eye on that. And we will also have 30 minutes or about half the time will be for presentation, and maybe a little less than that will be for Q&A at the end. So Dr. Williams is giving me a look. Maybe I'm cutting off her time, but you take as long as you want, and then we'll do Q&A at the end, whatever time we have left. And if you have questions during it, I'm sure she'd be happy to answer. We really want you all to feel like this is a space that we can have conversations and discuss the topic that we're covering today. We like to ask three things while you're listening. If you can think about maybe your main takeaway. Another thing is to think about some challenges that you might have faced in dealing with this topic, or also the third thing would be something positive that you've experienced in dealing with this. So we'd love to hear from you all when Dr. Williams is finished, if you want to share those thoughts. And I think that's all I have. So let's get started. I'll hand it over to Dr. Williams. We're so glad you guys are here today with us. Thank you.
Thank you so much, Emily, for that introduction. My face showed the 30 minutes. Like, wow, I have slides, you guys, and I hope that I can get through them and provide some time for Q&A.
You take as long as you need. We're here to hear from you, and we're excited about it.
Okay, I'm going to share my screen. And you should be seeing it now. Yes? All right. So as she said, I'm Lovoria Williams. I'm an associate professor in the College of Nursing. And I developed this presentation from a slide deck that had literally over 100 slides in it. And so I try to condense it to those most frequently asked questions from a new person who's endeavoring in tobacco cessation. So let's jump right into this presentation. So what I'm going to try to accomplish today is really just describing the benefits of combining medications and counseling. We're going to talk about how to prescribe these medications, the most common side effects, the best way to manage the patients with the education of the medications, and then try to identify the impact of these decisions on patient management. And lastly, we'll have a little bit of discussion about special populations. So everything that I'm talking about today is really being guided by the clinical practice guideline that we've been using since about May of 2008. So I would strongly advise you guys to read that document. It's very detailed, and it's a great guide for individuals who are new in providing tobacco treatment, as well as for those of us who've been doing it for a while and just need to go back to the basics to kind of understand the treatment rationale for what we're doing. The 5 A's I cannot emphasize enough. And that's our role as clinicians, as public health practitioners, to ask every patient about their tobacco use. And never assume that a patient, because of their background, their comorbid conditions, that they are not willing to make a quit attempt. The best evidence that we have about tobacco cessation is that clinician recommendation to quit smoking is the best indicator of a quit attempt. We want to advise all of our tobacco users, no matter what form it's in, to quit, because we know that that is the very best thing that they can do for their health and the health of those around them. I always include that in my advice to my patients, that it's not just about them, it's about those individuals around them that they love. And then assess their willingness to make a quit attempt. And again, don't assume that a person who's smoking for 30 years, that they're not willing to make another attempt to quit. And then assist them, because it's very difficult to quit using tobacco. So it's our role to assist them. And then arrange for follow-up. So it's not enough to just give them something. We want to follow up just as we do with any chronic medical condition that we treat. And tobacco dependence is a chronic condition. It starts with that medical history. We as clinicians know that 80% of our treatment guidelines is based on what the patient tells us. So take the time to listen to the patient and get a thorough medical history. We're very familiar with the Fagerstrom test. Talk to the patient about what they've used previously, who their support system is, what medication they prefer to use. Because if you guys are doing tobacco treatment, if you're like me, you have your favorite drug that you'd like to use, but it's not always the patient's favorite drug. So take the time to listen to what it is that they've tried in the past and what they would use. And then provide the education that they need to guide them on what to expect with their treatment. So there are just a few medications. We're very familiar with nicotine replacement therapy. It comes in 5 forms, and we're going to talk about each one of those. And then there are the non-nicotine medications, Wellbutrin and Chantix. Keep in mind that all individuals who use tobacco should be offered medications, except when there's a contraindication for the use of medication. Combining medications with counseling is the most effective. So when feasible, and in an evidence-based tobacco treatment clinic, there should be opportunities for the medication use as well as counseling. Remember that nicotine dependence is not just the physical dependence, it's that psychological dependence. And that's what the counseling helps with. It helps them prepare to live tobacco-free. It helps them learn when and how to empty those ashtrays, what those triggers are, and what they can do to overcome those triggers and understand them. So that's the benefit of counseling. This table shows data from 18 meta-analyses that really look closely at combining medication with counseling. And what it shows is that the more counseling sessions that an individual undergoes combined with the medications, the more likely the odds are that they will be effective in their quit attempt. So what first? Which medication should you consider first? It's really based on the current amount that the individual is using, their previous quit attempts, what's worked for them in the past, the severity of their dependence, and what they prefer or experience with the medication of their choice. And then it's individualized, because what I'm going to provide to you all are the treatment guidelines per the guiding document. However, what I've learned from my tobacco treatment days is that individualized approach are the best. So it's based on the patient's withdrawal symptoms, controlling their cravings and their urges, and really keeping them in remission, so maintaining abstinence. And then we adjust the dose and determine the length of treatment based on the patient's response and their side effects. Because sometimes there are medications that we use with the patient, and the guidelines may say that we should start with a certain dose, but if the patient isn't tolerating it, then they're unlikely to continue it. So we have to adjust the doses based on the patient's side effects. And then that return visit. So it's not enough to just provide a medication and hope that they quit. You want to have a return visit, just as you would for your diabetic patient, just as you would for your patient who's experiencing depression, so that you can follow up and monitor how they're doing. Now, if you're a busy clinician, you may not be able to do that in person, but you can do it by phone, you can do it by telehealth, or you can even have that follow-up visit with the counselor. And that's the way we did it in my practice in Georgia. So nicotine withdrawal is a constant craving for the cigarette. I've had my patients tell me that they quit smoking 10 years ago, but if given the opportunity, they would smoke a cigarette a mile long if they had a chance to do so, because that craving will continue. Sometimes patients complain of being irritable, inability to sleep, anxious, angry even, and even depression. If you think about nicotine and what it does, that reward sensation that it gives a patient, that can cause depression. It's like losing a good friend that made you feel good, that you associate with relaxing and having a good time. So there can be depression associated with withdrawal. What the medication does is it helps control these withdrawal symptoms so that the patient doesn't have to go cold turkey. And many will say, well, I'll just go cold turkey. Yeah, well, you can do that, but why would you do that when there are good medications that can help you? So the withdrawal symptoms typically peak within 1 to 2 weeks after quitting, but it may persist for months. And from my veteran population, those are the ones who tell me, well, it persists for years. Even though they will not smoke, that desire to do so will persist. How long withdrawal lasts, it really depends on how long the patient has smoked, the amount that they've smoked, their individual biology, and that can vary from person to person, obviously, and their support system. That support system, if possible, it would be great if they're a part of the cessation, because we have to help them understand that their role is to provide support, not to shame them, not to say, oh, I thought you were going to quit and look at you, you're smoking, but to just provide that support. And then as clinicians or tobacco treatment specialists, we need to arm our patients with knowledge, providing that anticipatory guidance that they need to know what to expect regarding their withdrawal as well as their treatment. So let's start our discussion with nicotine replacement therapy. There's been a lot of research done on nicotine replacement therapy. We know that it has to be delivered topically. It can't not be delivered as a medication because of how it's broken down by the liver, that it bypasses that first pass of the liver, so it's not administered that way. With all of these medications, generally speaking, the recommendation is that the patient do not smoke when they are using nicotine replacement therapy, because they could develop nicotine toxicity. Nicotine toxicity is when they have severe headaches, nausea, vomiting. They can even have GI complaints, dizziness, blurred vision. very severe symptoms of nicotine toxicity if they use nicotine replacement therapy and a high level of cigarettes. So how does it work? So skeptics might say, well, why would you even use nicotine replacement therapy? I mean, it's just the same as cigarette smoking, but really it isn't. It replaces the nicotine from the cigarettes. And what it does is it gives a much slower and longer acting profile, and it desensitizes and inactivates the nicotinic receptors, and it reduces the nicotine withdrawal symptoms. It comes again in the gum, the sprayed inhaler, and the lozenge. It's faster acting, but more short-lived than if they are using nicotine. So the rationale for use is that if we use nicotine replacement, that their success rate is twice that of just going cold turkey. It prevents the withdrawals. It also increases success rates by preventing those withdrawals while the patients psychologically withdraw and can be managed with the behavior modifications. So again, the highest success rates are for patients who are highly motivated to quit and have a moderate degree of dependence on nicotine. So the advantage of nicotine replacement therapy is that they're not exposed to the carcinogens that are in the cigarette smoke, and it provides this lower, slower, and less bearable plasma concentration rates of nicotine than the cigarettes does. There are some precautions. Generally speaking, an individual who's had a heart attack within the last 4 weeks, it should be used with caution. Individuals who are having cardiac arrhythmias, people who are having unstable angina, a person who has TMJ should avoid the gum for obvious reasons. People who are hypersensitive to nicotine, which in my experience, haven't been very many, used with precautions in pregnancy, and for individuals who are having microvascular or surgical procedures. So let's start with the gum. So the length of time for treatment with the gum is typically less than 12 weeks. The gum is most useful when it's used in combination with the patch or with Wellbutrin. The dose is less than 24 pieces a day, but you want to start the patient with taking at least one piece of gum at least every 1 to 2 hours so that they're not having this up and down of withdrawal. So you want to achieve kind of that steady state of nicotine so that they don't experience as many withdrawal symptoms. If they're smoking less than 24 cigarettes per day, you want to start with a 2 milligram dose of nicotine gum. If it's greater than that, then you want to start with 4 milligrams a day. Or if you have an individual who smokes within 30 minutes of awakening, they may be more physically dependent, so you may want to start with a higher dosage. The side effects are mostly GI related, hiccups, gastric reflux. Some patients will complain of mouth soreness, and we'll talk a little bit more about how to prevent that. Some of these symptoms you can manage with just over-the-counter antacids. So patients will tell you, well, nicotine gum doesn't work. And the reason they say that is because they don't know how to properly use it. They'll pop it in the mouth like it's a piece of spearmint gum instead of using it the way it should be. So what you want to teach them is to put it in their mouth, chew it until they feel this tingling, kind of peppery sensation in their mouth. And once they feel that, to park it on the side of their mouth and leave it there until that symptom of tingling and peppery sensation goes away. Once it goes away, then they should start chewing it slowly again Once it starts to tingle, they should park it again, and they should repeat these steps. It usually takes about 1 to 4 times of repeating this until they no longer get that tingly sensation. So generally, they should chew at least 9 pieces of gum per day. Again, on a fixed schedule of every 1 or 2 hours. And when they're chewing the gum, they should avoid acidic foods, coffee, wine, or soft drinks about 15 minutes before or while they're using the gum. Keep in mind that although they should use at least 9 pieces of gum a day, if they are heavy tobacco users, you will want them to use even more pieces of gum a day. For some people, you may consider tapering there. If they start with a 4 milligram, you may consider tapering it to 2 milligrams over time. The next one is the lozenge. Again, it comes in 2 and 4 milligram dosage, very similar to the gum. It's similar to a piece of hard candy. It dissolves in their mouth. They should not chew it and they should not swallow it. They should take about 1 every 1 to 2 hours for the first 6 weeks or so, and then 1 every 2 to 4 hours for weeks 7 to 9, and 1 every 4 to 8 hours during the final weeks of up to about 12 weeks. However, again, the recommendation is for gum and lozenge to the duration of treatment to be about 12 weeks, but it really depends on how well your patient is doing. So you may have to use it for a longer period of time. It is important that patients don't exceed 20 of the lozenge over a 24-hour period. So how to dose it? So again, unlike other forms of nicotine replacement therapy, which really relies on the number of cigarettes smoked per day, the recommendation based on clinical trials for the lozenge is that it's based on the dosage is based on the time of their first cigarette upon awakening in the morning. So if they smoke their first cigarette more than 30 minutes after waking in the morning, then it's okay to start with the 2 milligram dose. But if they're putting their feet on the floor and putting that first cigarette in their mouth before 30 minutes, then starting with a higher dose of 4 milligrams. Very similar to the gum, they should use it on a regular schedule, place the lozenge in their mouth and allow it to slowly dissolve. It usually takes about 20 to 30 minutes to dissolve, and they should rotate it to different parts of their mouth. Now, they shouldn't park it in their mouth. They should just, like they do the gum, but they should just rotate it around to different areas of their mouth as they're kind of sucking on it. And what that does with the rotation is it stops the lozenge from staying in one part of their mouth where it's more likely to cause some irritation. The nasal spray. So the nicotine nasal spray, it started in about 1996 is when it was approved for use. It's the quickest way to deliver nicotine to an individual who's undergoing cessation. It's the fastest, and it's really good for individuals who are highly dependent on cigarettes. Those individuals who need to relieve that urge as quickly as possible. It's similar effectiveness-wise as the patches and the gum. And again, most beneficial for those individuals who are highly dependent on cigarettes. It comes in a metered dose. The efficacy has been demonstrated to be similar to that of the gum and patches at 6 months and 12 months follow-up. The most common side effect is the nasal irritation, which is the most frequent reason for patients quitting the use of it. The recommendations for how to dose it is 8 to 40 doses per day. A dose is equivalent to a spray in each nostril. For the patients, when you start them on it, if you can get them to hang in there for the first week or so, the nasal irritation and the throat irritation, it begins to subside. You have to help patients understand that if they've put it down and not used it for a day or so, or for the first time that they use it, that they need to prime it by taking a Kleenex and shooting about 6 or 8 sprays into the Kleenex to bring the nicotine spray up into the top of the dispenser. They should store it away from pets and away from their children. For use, if they are congested, they should blow their nose before they use it, tilt their heads back a little bit, put the tip of it into their nostril as far as comfortable, and then breathe through their nose as they spray into it. They should not sniff or inhale while they're spraying it. And then they should wait about 2 minutes after they use it before they blow their nose. They should breathe through their mouth as they take that breath in. And they're not trying to help them understand that they're not trying to inhale it so deeply that it goes into their lungs, that it should be absorbed through their nasal mucosa. The other form of spray is the inhaler, and it's the newest form of nicotine delivery. The dosage is about 6 cartridges per day, up to 16 cartridges. It's absorbed through the buccal mucosa. The great thing about it, and why patients tend to like it, is that it satisfies that hand-to-mouth ritual that they've had from cigarette smoking. So what the patient does is they kind of put it in their mouth and they puff on it, kind of like a pipe somewhat. And it's absorbed through the mucosa. Very little of the nicotine reaches their lower respiratory tract. And as they're inhaling it, they get about 80 puffs over the 20 minutes that they use it. It's quickly absorbed, not as quickly as the spray, but it is very quickly absorbed. In about 15 minutes, they have what's equivalent to having smoked a cigarette. Again, it really helps with the physical withdrawal from the nicotine because it helps overcome that behavior sensation of the hand to mouth. And it results in a 2-fold increase in the 1-year quit rate compared to placebo. Again, the dosage of the inhaler is very individualized. The patients tend to like it because they can really adjust their dosage, the number of cartridges that they use in a day, to what their physical withdrawal symptoms are. Again, though, they should start with at least 6 cartridges in a day. And they should stay on the inhaler for at least 3 to 6 weeks. And they can use it for recommended up to 12 weeks, but I've seen patients be on it for much longer. And they can actually wean themselves off from the inhaler. Keep in mind that patients with asthma and other respiratory conditions, that you want to use this very cautiously with that patient population. So again, the length of treatment is 12 weeks, about 6 months. I've seen it used much longer than that. The most common side effects are the mouth irritation, the cough, and the rhinitis. For nicotine inhaler, very similar to all of the other nicotine replacement therapies, that patients should stop smoking before starting to use the inhaler. When they're using it, they should use it for at least 20 minutes each time. The cartridge must be used within a day. After a day, they must dispose of it. And again, the recommended use is for no longer than 6 months. But again, I've seen it used longer depending on the patient. So the nicotine patch, one that we're very familiar with. So the nicotine patch is based on the number of cigarettes a day. For an individual who's smoking less than 10 cigarettes a day, they should start at the 7 milligrams up to the 14 milligram a day patch, 10 to 20, 14 to 21, 21 to 40, 22 to 40 milligram patch per day. And greater than 40, 42 milligrams or more. So an individual could theoretically use more than one patch at a time as their dosage based on the number of cigarettes that they're using per day. So when do you start? So patients should start using their patch on their quit day. However, there is some new evidence that suggests that a patient could start using the patch before their quit date. That in doing so, that it increases the odds of their being successful in their quit attempt. The patch tends to be more useful when used in conjunction with a shorter acting nicotine replacement therapy, such as the gum or the lozenge. I always prescribe the patch with the gum or the lozenge because it really helps with the withdrawal symptoms, because that patch is going to give a slow, sustained release. And if an individual is craving, the gum or the lozenge will help with that immediate craving. For patients, again, they will sometimes tell you that it doesn't work or that it causes irritation. You want to tell the patient to apply it to a part of their body that has the least amount of hair. So their upper body somewhere on their bicep, if they have a hairy chest, or higher on their chest. They should never cut the patch, and they should replace it every day. They should remove it at bedtime, or if they're having an MRI, they should remember to remove that patch before getting into the MRI. And they should dispose of it properly, especially if they have small children or pets. You want to ask them to remove the patch, fold it inside of itself, and to throw it away into a closed container. Sometimes patients will say, well, I don't want to use the patch because I'm a swimmer, or I tend to use it, I forget to remove it when I shower. They shouldn't have to. If they've placed it on properly, it can be used in the pool or in the shower. Again, typically patients stay on the nicotine patch up to 8 weeks. If they're still smoking within a month, then adding the gum. But I suggest that when you start the nicotine patch, that you go ahead and give them a gum or lozenge in connection with that's going to help them with their cessation attempt. The skin irritations, It's a reason patients will say, well, I'm allergic to it, so I stop using it. You can avoid that by reminding them to rotate that patch, that when they remove it, that when they put on their new patch, to wash off that adhesive and rotate it to a different site. They can also use a low-dose cortisone topical to help with that irritation. And when they rotate, if they could rotate, not use the same spot for about a week, that also helps. We ask them to remove the patch at bedtime because sometimes they will complain of insomnia, or they will complain of having vivid dreams with using the patch during the night. Some patients will need their patch though at night. So you can advise them to remove it at bedtime, but they don't necessarily have to remove it at bedtime if they're waking up in the middle of the night craving a cigarette, that is. Headaches is another frequent complaint of using the patch. So in summary, the advantage of using the patch is that it does give that consistent level of the nicotine. Some people don't want folks to know that they're attempting to quit because of the social stress and pressure of people knowing that they're quitting. So they like that they can conceal it. And there's very few compliance issues with the patch if you provide them a good education. The problem with it is that they cannot titrate up. We do tend to titrate them down off from the patch, but unless they're in close communication with their clinician, the dose that you prescribe is typically what they will stay on until they return. The length of treatment is generally 8 weeks, but again, I've seen it used for 6 months and even longer. I tend to step down with my patients, starting with 21 milligrams, and then going down to 14, and then going down to 7 over about 6 to 8 weeks. Again, the patient should put the patch on immediately when they wake up in the morning, and to avoid that local irritation, the methods that we've previously discussed. So here's a slide just talking about the efficacy of nicotine replacement. Most of the clinical trials have been done on the gum and the patch. However, data indicates that there's high effectiveness with the inhaler, the lozenge, and the spray, as you can see from this. Can it be?
Dr. Williams, we had a question in the chat, if I can interrupt you for just a minute.
Yes, you can.
The question is, I believe those who vape have higher levels of nicotine in their system. Which NRT works best for their plan for treatment?
Again, that's one of those areas that there's new data and no clinical practice guideline on just yet. So individualized treatment, I would say if an individual is using a vape, that they might benefit more from the inhaler because of that effect of that use being similar as a vape. But there's not a lot of clinical trials guiding us on that just yet. Good question. Were there any others?
No, that was it.
Okay, all right, great. So again, long-term use, up to 6 months for any of the nicotine replacement therapies. However, there's no known health risks and very low dependence for longer use, because your patients will say, I still crave. Is it okay if I continue to use a lozenge every now and then, or keep some gum on hand? And the short answer is yes, it is probably safe. There's no evidence to suggest otherwise. And now on to our oral medications. So bupropion or Wellbutrin. It's an atypical antidepressant, and it's thought to work. Really, we're unsure how it works, but it's thought to work through affecting the levels of neurotransmitters of the brain by blocking the neurodopamine effect of neuroepinephrine uptake. And that works by decreasing the cravings for the cigarettes, and it also helps with decreasing the symptoms of withdrawal. It has to be used very cautiously in individuals with a history of seizure disorders, head injuries where they lost consciousness. We don't want to use it in combination with Wellbutrin that's being used for treatment of depression. We don't want to use it in individuals who are using MAO inhibitors in the last 14 days, individuals who have anorexia or bulimia, people who are withdrawing off from alcohol or benzodiazepines. It has been safely used with SSRIs. And one benefit of using bupropion is that it does help with the weight gain that patients typically will see after they quit tobacco use. And it may be more effective among women. But the strong contraindication is for individuals with seizure disorders. I would suggest that you do not use it at all in individuals with seizure disorders. So how do you use it? The treatment should begin while the individual is still smoking or using tobacco. So with up to 1 to 2 weeks prior to their quitting. Initially, you start at low with 150 milligram tablet every morning for 3 days, then increasing to twice a day. You want there to be about 8 hours between the morning dose and the evening dose, but because of the side effect of insomnia, you want them to take it before 6 o'clock in the evening if possible. The duration is 7 weeks up to 52 weeks. It has been used for up to a year safely. The great thing about using bupropion is that it can be used with all forms of nicotine replacement therapy, and there's no taper necessary for using it. The common side effects, again, is insomnia. Again, try to avoid this with getting that evening dose in as soon as you can, up to 8 hours after that morning dose. Another very common side effect is dry mouth. I don't hear patients complain of tremor or skin rash very often, but that is one of the side effects. So this slide is showing a clinical trial that compared bupropion alone or bupropion with a patch. And as you can see that it's more effective if it's used in conjunction with a patch. And then my drug of choice is Chantix. It works by binding with the high affinity of nicotine acetylcholine receptors. And it's believed to be effective. It results in a low-level agonist activity at the receptor site. And what it does is it inhibits that nicotine binding. So in other words, what it does is it stops the patient from getting that good feeling that they get when they take that long inhalation of the cigarette. It blocks that reward effect. So in essence, what patients will tell you is that when they started using Chantix, in the first few days of using it, that they were smoking with no benefit because they weren't getting that good feeling that they typically got. How it's dosed is 1 week prior to quitting, the patient starts using the Chantix. It's dosed at 0.5 milligram for 3 days. So they take it once a day, up to 3 days, 0.5 milligram. From day 4 to 7, they take 0.5 milligram twice a day. And then starting at day 8, they take 1 milligram twice a day. My patients tend to tell me that by day 4, when they begin to titrate up to twice a day, that they no longer want to use cigarettes. The reason for increasing the dosage slowly is that the most common side effect is nausea that patients complain about quite frequently. So sometimes even dosing it up to 0.5 milligram twice a day at day 4, that you're unable to do that because the patient is continuing to complain of nausea. And if that occurs, then you just keep them on the 0.5 milligram once a day until they're able to tolerate it. Another more common side effect is vivid dreams. So not nightmares, but patients will tell you that they didn't used to remember their dreams, but now they remember their dreams, and they remember their dreams very vividly. And insomnia is another very common side effect. Some patients will say that the cigarette no longer gives them the reward, and that it tastes bad, and other foods also taste bad. Oh, another caution is in individuals who have renal dysfunction. You want to check their renal function before starting the Chantix and monitoring it very closely while they're in treatment. The vivid dreams tend to subside with use, and the same with the nausea. You want to caution your patients about changes in their mood, especially in patients who have a history of depression. So the recommendation is that we monitor all patients very closely for neuropsychiatric symptoms once we prescribe Chantix. Individuals who have psychiatric illnesses such as bipolar disorder, that Chantix may worsen it. So that was the original recommendation in 2008. However, since that time, newer evidence has shown us that there isn't really a significant increase in neuropsychiatric symptoms with the use of Chantix, and that the benefit of using it might outweigh the risk. But I would just caution you to be very cautious with your patients who have underlying depression if you decide to use Chantix with those patients, and bring them in for follow-up more quickly than you would someone who doesn't. But caution all patients to monitor how they're feeling and their mood when they're using Chantix. So special considerations. Special considerations are regarding smokeless tobacco users. Again, there's not much evidence with it, but there is some evidence of nicotine replacement therapy for patients who are using greater than 3 cans or pouches of smokeless tobacco, using a dosage up to 42 milligrams, and for fewer pouches or cans of smokeless tobacco of using a lower starting dosage. But again, the body of evidence to support how to use it in smokeless tobacco users is not as strong as it is in the use of cigarette smokers. In our Practice, we recommend that individuals who are using smokeless tobacco have an oral exam with their dentist or hygienist, that we combine it with a bupropion or use nicotine replacement therapy with it. We've also found that using lozenge for nicotine replacement were effective for individuals who use smokeless tobacco. But again, that individualized, tailored approach for individuals who use smokeless tobacco. And there's some studies that have shown effectiveness with oral medications and smokeless tobacco. Your patients will ask you about hypnosis and acupuncture, and the short answer is that there's very little evidence that beyond anecdotally that it's effective. Pregnant patients, the strongest association with quitting smoking in any patient population is clinician advice to do so, especially with pregnant patients. So advise them to quit smoking and connect them with a counselor. All of the nicotine replacement therapies are category D for pregnant women. There's some evidence to suggest an intermittent dose of nicotine replacement therapy and removing the patch at night, as you would with other patients, may be effective. When you have a pregnant patient who is a heavy smoker, when the benefit of using nicotine replacement or other medications outweighs the risk of their continuing to smoke. There's no evidence on the effectiveness of Chantix or the safety of it among pregnant women. However, there are some case reports of women who were in clinical trials and they were using Chantix and they were pregnant and they didn't have any problems. There's no indication that none of the medications have long-term effects on smoking in pregnancy. So again, the recommendation is to use it only in the instance when the benefits of using it outweighs the risk. 5 minutes. Patients who use neuroleptics, we know that among individuals in the psychiatric population that the prevalence of smoking is as high as 70%. Again, using the standard approaches of 5 A's and not being biased in the approach that they have too much going on psychologically to attempt to quit, to approach them as we would any patient and advise them with the 5 A's to quit tobacco use and providing them support to do so. There is some evidence to suggest that cessation might worsen, exacerbate their psychiatric symptoms, and that it may affect the effectiveness of their anti-psychiatric medications. So monitoring these patients very closely, bringing them in to see you, doing their cessation attempt, and using a tailored approach in helping them with their quit attempt, and using a very individualized approach based on their high tobacco use, and knowing that an individual who's using 2 to 3 packs of cigarettes a day, using a standard approach of 21 milligrams of nicotine replacement patch may not be effective in them. So carefully individualizing their approach and bringing them in frequently to see you. So in summary, there's lots of options to treat our patients for nicotine addiction. Strongly advising them to use these options and not go in cold turkey, because these medication options are certainly more effective than placebo or going cold turkey. taking that thorough history that's necessary to guide you in which medication approach to use based on what the patient desires. And combining all medications with counseling, even if it is the counseling line where they can talk to someone over the phone if they're unable to come in for that counseling. We still need more data, clinical trials on special populations, such as individuals who are suffering from mental health disorders, individuals who are using newer forms of nicotine, such as vaping and e-cigarettes, that more data to guide our practice is necessary. Here are my resources. I advise you to download the PDF of the treatment guidelines and reach out to me if you have additional questions. I'm happy to answer them. And in the 2 minutes that I have left today.
Thank you so much, Dr. Williams. That was a wonderful presentation. We do have a couple minutes for questions. Does anyone have anything? You can put it in the chat or just unmute yourself and ask.
Actually, I have a question. Lovoria, if I email you, could you maybe give me a few suggestions? Our doctors do not feel comfortable ordering more than one 21 milligram patch. And, you know, mentally ill patients are pretty big, heavy smokers.
Yes. Yes.
You know, our patients use a can or two a day, or they smoke 2 to 3 packages of cigarettes a day. So, you know, I'm looking at too comfort for our patients.
So my short answer to that would be for them to use the highest dose patch there is and combine that with a short-acting lozenge or gum and bringing that patient in and connecting that patient to counseling.
We don't use gum. It ends up everywhere. And lozengers, we were working on a study about expense because patients would much rather have the lozengers, but they just don't feel comfortable ordering more than 21 or ordering anything else with them either. So that's the problem I have here.
Yeah.
And I'm looking for patient comfort.
You know, I think, Karen, that, you know, we are really into evidence-based treatment. And we really nail that into all of our clinicians, our nurses, our physicians. But in that special population, we have to really individualize treatment while we're building the evidence base to guide our treatment. And I understand their discomfort, but yet we have to treat our patients.
Yeah. I might try using some of that to put something together. So
well, reach out to me. I'm willing to help.
Okay, thank you.
Thank you guys for coming.
Thank you all so much. I dropped a link in the chat. If you all want to help us provide feedback for today's seminar, that would be great. And there's also some links in the chat that Heather put in that would be really helpful resources that tie into today's presentation. Heather, did you want to say something? Oh, I thought you unmuted. Okay. Thank you guys so much. It was great having you today. Good to see everyone.
Thank you. Thank you, Dr. Williams.
Thank you for coming, Heather.
Thank you so much, Dr.
Williams. Thank you, Emily. Bye-bye.